For the rest of the time, I got to get into this red blood cell thing with you. Okay? Males have more red blood cells than females. No, okay? It's because we have more muscle mass. Okay? The structure, as I explained to you, is that it's biconcave, right? So we have a red blood cell over here. It looks like there's a hole there. It doesn't. But if I did a side view, it would not look like this. It would be more looking like this. Side view. It's concave here and it's concave here. So it's biconcave. Does that make sense? It's because there's no nucleus, so it kind of shrinks down. Okay? There's essentially no organelles in there. The only thing that's in there really is something called hemoglobin, a protein that likes to bind to oxygen. So if there was a nucleus in there, it would occupy a large amount of space. So why don't we take out the nucleus and we could stuff this more with hemoglobin to allow more oxygen to go onto the red blood cell. And that's just why, or that's just the reason why we do that. You've always heard this, and you'll hear it again and again and again in this course, but physiology reflects anatomy. Function reflects structure. There's a reason why that there's no nucleus here. It's not because we just memorized it. It's so that through evolution, if we remove the nucleus, we could stuff more oxygen. We're oxygen beasts. We need oxygen to survive, to make ATP. So we got to stuff a lot of oxygen in our bodies. Okay? So hemoglobin is this protein that can aid in binding oxygen to it and carry it from one place to another. Okay? There's something called spectrum. Spectrum is a protein that gives the red blood cells its shape. Okay? It gives it this area over here that can bend, so it can go through those very narrow passageways of capillaries. In a person who doesn't have spectrum, and that does happen, it's a rare disease, it's called spherocytosis. What happens to them is that their cells, their red blood cells, are more or less like balls. All right? That's a reflection. All right? They look like spheres. That's why they give it the name spherocytosis, okay, as a disease. These are going to have problems. If you have a capillary, and a capillary is like this can squeeze on in here. This cannot. This will get clogged in here, and then we have problems, okay? So, like I said, the red blood cell structure has evolved so that we could do gas transport, okay? It complements very nicely, okay? It has that biconcave shape, all right? And that'll increase the surface area, all right? Surface area here, what I'm saying by surface area, we can actually absorb things over here and here, but look at this. You can absorb things here and here, here, but now you can actually absorb things on the sides like that. So you increase surface area, okay? Like I said, the red blood cell contains about 97% hemoglobin. 4 molecules of oxygen can bind to 1 molecule of hemoglobin, okay? And what's nice about this is that the red blood cells, the way it's made, is that it doesn't need to use up the oxygen it's carrying. It would be very bad for us to have potato chip factories and the people making the potato chips are eating the potato chips. You're not going to be able to sell many of them. Does that make sense? Same way here. The way it's developed is that the red blood cells don't need to use the oxygen that's in there. Okay? So this is what red blood cells in us look like. This is what red blood cells in salamanders look like. They have their nucleus. We don't. All right? I won't really ask you about that, but if you've had biology before, that might help you a little bit. And this is what it looks like. You don't have to worry about the sizes of them. histology course when you take it for a whole semester. You'll learn all about that. So let's talk about hemoglobin. What's nice about hemoglobin is that oxygen can bind to it and can come right off of it very nicely. Okay? So it binds to it and it reversibly comes right off, which is what you want. You don't want it to stay on there forever and it never comes off to go to your tissues. Okay? The hemoglobin has this protein called globin, and it's made up of, MUO is made up of two, well actually it's made up of 4 chains. 2 alpha chains and 2 beta chains. Okay? Each chain is bound to what we call a heme group. And in the center of a heme group is that we have iron there. That's why you need iron in your diet. Okay? So like I said, there's 4 heme groups to 1 hemoglobin. That means there's 4 oxygen molecules combined to 1 molecule of hemoglobin. Okay? Now, the best way I can explain to you what this is all about, on how this is all formed, won't have to draw these out, but you should have an idea of what's going on here. And it's a quick review from A&P. Actually, it's a quick review from your first biology course, when you did cytology. When you have the amino acids all together, a long chain, cysteine, histine, cytosine, methionine, and so forth. You learn all about those later, or early. So when you have this, where the amino acids in a certain particular order, we call this the primary structure. Now, I'm just going to draw it as one line instead, because it makes my life easier with explaining the rest of this. So that's the primary structure. If you take this primary structure and you start coiling it like that, that's our secondary structure. Okay? It's like a slinky. If you take this slinky and then you start doing this with it, bending it a little bit, then this is our tertiary structure. Okay? And what's holding here is hydrogen bonds. Okay? Creates this three-dimensional thing. Then what you could do is that you could actually take one of these chains, put it here, another chain, I'm just making it smaller so you can see it, another chain over here, another chain over here, another chain over here. Now that's the quaternary structure. Not because there's 4 things in here, I just happen to draw that there's 4. I could have had only 3 things, and it could still be called a quaternary structure. But we are putting 4 chains here. 4 of these suckers on here. Okay? It just happens that maybe 2 of them are what we call beta chains, and 2 of them are alpha chains. The amount of which amino acids are on here, that determines alpha and beta. If we put right in the center of each one an iron, then I just made a molecule of hemoglobin. One oxygen combined here, one oxygen combined here, one oxygen combined here, and one oxygen combined here. That's how hemoglobin is set up. This is a tertiary structure, it's all bent. That we're trying to show you is a heme group. When you put 4 chains together here, you've got hemoglobin. That's hemoglobin right here. 4 chains. 1, 2, 3, 4. They're showing alpha 1 and alpha 2. There's 2 alpha chains, beta 1 and beta 2. There's 2 beta chains. And in the center, you have this green thing called a heme group. This is a blow-up of the heme group. But look what's smack dab in the middle, Fe, iron. Okay? You won't have to draw this out. I'm not going to add this. It's not a chemistry course. But the overall understanding of how hemoglobin molecule is made up, you should know. Okay? Now we have different types of hemoglobin. And these different types allow the oxygen to be bound tougher to the heme groups or not. And in certain stages of your life, you need it to be doing that. We have embryonic and fetal hemoglobin. The oxygen wants to stay on it longer because the lungs aren't working in the fetus, so it needs to stay on a little bit longer because it doesn't get the oxygen like an adult would. So right there we have different types. We could have hemoglobin with oxygen on it. We could have hemoglobin without oxygen on it. We could have hemoglobin with carbon dioxide on it too. All right? Not much of that's on there. About 7% of your carbon dioxide in your body is attached to hemoglobin. The rest of it's not. I'll get into those later. So a brief understanding about carbon monoxide. You've heard of this. Carbon monoxide, the main thing I want you to understand is that, one, it's in cigarettes. Okay? Not trying to push you not for smoking, but I mean, education is probably the only thing, you know, at least you guys know about what's going on and you make your decision about what you want. But 20% of cigarette smokers' hemoglobin cannot transfer oxygen. What happens is carbon monoxide binds the hemoglobin and it doesn't want to come off. It's on there with like glue. So you can only work with 80% of your hemoglobin. All right? They have a very strong magnetic attraction, affinity, whatever you want to call it. And we'll talk more about carbon monoxide when we get into respiratory. Sickle cell anemia. Sickle cell anemia, what happens here is that people who have sickle cell anemia, their red blood cells are not like this. They're not round. They're not concave like this. Instead, they become crescents. Sometimes they'll look like areas like that. The top view, not the side view. The problem is with sickle cell anemia is that oxygen can come onto the hemoglobin, but it can't come off. It's difficult for it to come off. Okay? And that's what's going on with this. All right? That's what, so this is what hemoglobin normally looks like. The structure, kind of showed that just before. And your red blood cells look like this. In a person who's got sickle cell anemia, it looks all scrunched up here. And their red blood cells are more like sickle shaped. This can cause crises. They go through the bloodstream and they get clogged in there. And now the blood can't get from point A to point B because you have a motor vehicle accident happening in the middle there. So what happens is the area that needs oxygen needs it, so it sends a message to the brain saying, I don't know, brain, but I need more oxygen and it's not happening. So what I'm going to do is I'm going to cause a lot of pain. Hopefully my body will go to a hospital to see if they can get some kind of aid. See, pain is a good thing. Pain tells you that there's something going wrong. All right? You might not want the pain. I realize that. If you were numb, you wouldn't even know what's going on with your body. And that's one of the problems that we have with diabetics, because their nerves don't work all the time. All right? So then they don't realize that they stepped on a piece of glass. Well, same thing with sickle cell anemia. Well, not the same thing, but that's why they get these painful areas throughout their whole body, because the blood can't, the oxygen can't get from point A to point B. Okay? And what they'll have to do is remove the blood and put good blood in there. But that doesn't last that long. Like I said, 120 days.
Are you saying that without the pain, infection
In this case, or diabetes? Which one? Sure. I mean, there's no oxygen getting to a certain part of the skin, then that skin will start dying down. And when it starts dying down, remember, the skin is a barrier between the outside world and the inside world. So if that skin starts deteriorating, you open up a window to allow bacteria to come in. It usually doesn't happen that well with sickle cell anemia. The reason why is the pain is so excruciating, you're going to get help before you just let it run. Diabetics is a different story. They don't have pain, so they're not going to go seek out attention. Does that make sense? All right. I'm only putting that as an example to emphasize why pain is good.
It's crucial for the heart.
It's crucial for.
If it's crucial for the heart, if you don't have the pain, and you have blockage of oxygen, it's crucial for the heart.
Yeah, you need the oxygen. It depends on where that motor vehicle accident occurred. If it happened, you know, on the toe, you're going to get a lot of toe pain. If it happens, let's say, near the heart, you're going to have be like a heart attack. So it depends on what blood vessel has been affected with this clot there. Okay? Other questions? All right. And you did these kind of things with, you know, genetics. You did genetics with, I guess, your biology. Let me just do one really quickly, just so I could knock this off. But you have here, but you've done Punnett squares, right? All right. You would, if you do Punnett squares, which you're gonna have to do like 1 or 2, you know, for you to understand the concept over here on my exam. But only a 2 by 2, not this 4 by 4 thing. You know what I'm talking about, right? Okay. So, but it's easy to understand, right? If mom is over here, and that's the abbreviation for mom, for females, okay? And a male is over here, there's the abbreviation for males, rather. Let's say sickle cell anemia is the autosomal recessive trait. So the only way you can get sickle cell disease is that you have to have the recessive gene for both mom and dad. So let me show you really quickly. Mom is, let's say, and we'll use these letters up here. Again, the letters are just used arbitrarily. I could have used S, I could have used C, I could have used P or X, all right? So use H. No. So we have H over here, H over here, and a lowercase. So that is capital H, lowercase h, right? Dominating recessive over here. Mom has the same thing. So when you put these together, H, I kind of did color coded so you can see this. What happens here is that 25% of the offspring will be completely normal, right? Getting a dominant allele from mom and a dominant allele from dad, okay? However, 50% will carry the trait, the lowercase h. Now, they will appear normal, and they will live to a ripe old age of 100. There's no problems with that. They have sickle cell traits, is what we call it. Now, what they do with sickle cell trait is not all this red blood cells have sickles on. Maybe, maybe 10% of their blood, red blood cells, have sickle cells. You could live to, because you got 90% that is pretty good, you could live to a ripe old age with that, okay? However, 25% of the offspring will actually have the disease, okay? Which means that maybe 60 to 70% of their red blood cells will have those sickle cells. And then it's up to mom to decide if she has the trait. What's the next test you want to do if mom has the trait? What do you test? You test that, right? Because if mom has the trait, you want to test that. If he has this, then there's a 25% chance that their offspring will have sickle cell disease. And then it's up to her if she wants to abort the pregnancy or not. Don't get your thoughts in there. It's called autonomy. If she wants to, maybe she knew somebody in her family who had sickle cell disease, and that's what she chooses to do. It's up to her. All right? There's a course here. If you take medical ethics, definitely take it. All right? You do have to see how other people think. Okay? We just need to educate patients and let them make their decision on what to do. Okay? So that's what happens over here. Okay? If dad, let me just do this scenario, if dad gets checked and he has this situation, then he'll have this. Then this is what the prediction would be. So if she has a trait and dad doesn't have the trait, there's no reason to even entertain the idea of aborting the pregnancy, because 50% will be completely normal and 50% will be just like mom, which she wouldn't have any issues anyway. Does that make sense? Okay? It's when mom has it, we need to check dad. Okay? Questions about that?
So if both of them has wedding, so we can forget about it.
Correct. In that case, there's a 25% chance that the baby may have this sickle cell disease. Then it's up to her on what she wants to do.
Why not 100%?
Won't be 100% because 100%, let me go back to this one.
If both of them have the red age.
Both of them have the red age. Yeah, absolutely. Then yes. If, in other words, if she had sickle cell disease and he has sickle cell disease, yeah, there's a 100% chance. Does that make sense? I don't have to draw that one, do it? You understand that? It'll be all red. Okay. All right, that's just a quick review on that. All right, red blood cell life cycle. All right, erythropoiesis. All right, we talked about starting with the hemocytoblast. Now I'm going to go through all this really quickly. Okay, so this is the same thing I kind of showed you before, but it's just isolating just the red blood cells. Okay, and it's going this way instead of going down. You saw what I had before, but going this kind of thing. I kind of showed you earlier what which ones I want you to know. So in this case, same thing, but it's just the red blood cell form. Here's a hemocytoblast. That's our major stem cell to make all the blood cells. That will turn into, and you need to just know it goes into an erythroblast, and then from the erythroblast it turns into a reticulocyte. That's the point where the nucleus pops out, and now it's known as an reticulocyte. At there, it does a few other changes and eventually becomes a erythrocyte. And you will later understand when you get into your professions what a reticulocyte count, it determines the rate of erythropoiesis. All right? If we have medium levels, that's normal. But if you have extremely low levels, that means the production of red blood cells is very slow. If there's too much, then for some reason your red blood cells are making too much. It may be because you're losing a lot of red blood cells. So your reticulocyte count should be really high because your body's trying to compensate and working really fast. Does that make sense? So if we don't know if the person's losing red blood cells or not, I want to get a reticulocyte count. If it's really high, you're losing blood someplace. Where? I don't know. That's where you got to go for other tests. Okay? So that's the significance of understanding reticulocyte count. Now, the regulation of erythropoiesis, okay, is hormonally regulated. The amount of red blood cells that you're making have to equal the same amount of red blood cells that you're losing. If you're going to make, I'm just giving you numbers, if you need to make 100 red blood cells, or if you're losing 100 red blood cells, you need to be making 100 red blood cells. You've got to have that constant rate going on. Okay? Too many red blood cells, if you're making more than what you should be, then your blood gets thicker. The viscosity increases. And we talked about, or watched a video about polycythemia. Okay? So it's hormonally controlled, and it depends on an adequate supply of a few things. You need iron, and we talked about that. You also need amino acids, because amino acids are made of proteins. Is there a protein inside your red blood cell? Yeah, what is it called? Hemoglobin, okay? So you need amino acids. You also need vitamin B12 and folic acid also, okay? These are two vitamins that you need. If you're low on any of this stuff, you can't make your red blood cell, all right? You need to make potato chips. If you're low on potatoes or oil, you're not going to make potato chips, okay? So we have a hormone. Here's what you got to add now. But there is a hormone that actually will control the rate of red blood cell production. It's called erythropoietin, or EPO. Erythro meaning red, poietin, as I mentioned before, hematopoiesis. Poietin means synthesis of. So erythropoietin is a hormone that gets released by the kidneys to make red blood cells. Now, where does this come from, or what makes the erythropoietin come out? Low levels of oxygen, not low levels of red blood cells. Although, if you have low levels of red blood cells, you'll have low oxygen in your body. But it's geared, or it's actually stimulated by low levels of oxygen. So if you go all the way up in the mountains, there's less oxygen up there as you go higher. You have a good supply of red blood cells, but you're breathing in less oxygen. So you're going to need, so erythropoietin gets made more to make more red blood cells to carry that oxygen that, since you're so low on it when you're up high in the mountains. Okay? So that's what goes on over there. All right? Stimulated by hypoxia. And so it's going to increase red blood cell count, and it's going to increase the oxygen carrying ability for blood. So basically what's happening here is that if you're, this is what normal blood oxygen levels should be. If the balance goes low, if you have oxygen that's low in your blood, it's going to tell the kidneys to spit out erythropoietin to go to the bone marrow, and the bone marrow is going to make more red blood cells. And now the balance will go this way. Does that make sense? You have low levels of oxygen. That's going to stimulate the kidneys to secrete erythropoietin. Erythropoietin is a hormone that is going to go target the bone marrow. The bone marrow is a site where red blood cells are being made. So it's going to tell the bone marrow to make more red blood cells until it gets back to normal. So here's a typical question that I can ask. If you have kidney disease, why would you be anemic? You won't be producing EPO. So when you have, if you're going to be a nurse and you're working in a renal dialysis clinic, you're going to see a lot of the people that are taking, a lot of patients there, they're going to be on something called Procreate, which is a synthetic EPO, because their body, their kidneys can't make the erythropoietin. It makes sense, all right? Don't memorize, understand the concepts. Okay? All right? And then talk briefly about iron. All right? Iron is needed, obviously, to make heme for the hemoglobin. You have low iron, you're not going to make heme, which means you're not going to have oxygen bind to red blood cells. Okay? Now, the things that are needed to make a red blood cell, the raw materials, is iron, obviously, but you're also going to need amino acids to make proteins. And what's a specific protein? Thank you. What's a specific protein that is made, or what's the specific protein that's found in red blood cells and is loaded with it? What is it? Starts with an H, ends with hemoglobin. Oh, there it goes. Okay. All right. So you need lipids, you need carbohydrates, you need iron. You also need 2 vitamins, specifically something called vitamin B12 and also folate. So if you're missing any of that stuff, you're not going to make a red blood cell. So yes, think about it. You have low iron, you're not going to have red blood cells. You're going to have low folate, you're going to make less red blood cells. You have low vitamin B12, you're going to make less red blood cells. You're missing any of that stuff, any of those iron or vitamin B12 or folic acid, you're going to be anemic. Okay? The storage of iron, well, all the iron that's in your body, 65% of it will be found in hemoglobin. Okay? Other places it'll be found, the other 35% in bone marrow, spleen, and the liver. Okay? We have inside cells, we also have iron. Okay? And it's stored in these protein iron complexes called ferritin and hemosiderin. Okay? You'll see those words. A good example to show you where hemosiderin is, it has like a yellow color to it. You ever bruise yourself and then later on the bruised kind of, the black and blue turns into a yellow color, that's the hemosiderin. That's the residual hemosiderin that needs it, that you busted a few cells, and it released that hemosiderin out, and that's what that yellow color is until it gets absorbed into your bloodstream and used elsewhere. Okay. We also have circulating iron, and it's loosely bound to a transport protein called transferrin. Okay. So what happens to the red blood cell? It dies. The reason why it dies is because it has no nucleus. It does not have the power to go through mitosis. There's no nucleus there. So it lives for about 120 days. And as it gets older, it becomes more rigid and fragile, and it begins to degenerate. So we need to make more red blood cells constantly. As these dying red blood cells occur, they get engulfed by these macrophages. The macrophages used to be what in the blood? What did they used to be? What type of white blood cell? Monocytes. Good. Okay. So that's what happens to, iron gets, we recycle all this stuff so we can make more red blood cells. The hemoglobin gets broken down. Hemoglobin is a protein, so the globin itself is going to, which is a protein, is going to break down into amino acids, and we can reuse the amino acids. The heme can be broken down, and we could reuse the iron. Okay? So you can read this on your own, but I'm going to show you a short video of how this all gets broken down. And I got a picture showing this too. Also, if we have an excessive amount of destruction of red blood cells, for whatever reason, it's going to create a yellow color, as I mentioned before, the hemosiderin. Okay? So the excessive destruction of red blood cells leads to an increase of bilirubin, and bilirubin is the color of that yellow. Okay, it's a yellow pigment, and heme actually broken down to become bilirubin. When bilirubin goes into the interstitial areas of your skin, it appears as a yellow color. And if we have a lot of that throughout your whole body, we call that condition jaundice. Okay, and there's a lot of reasons why red blood cells be broken down. Okay, the yellow color, this jaundice, also appears in the scleras of your eyes, the white of your eyes. So that appears that too. Okay. Iron gets salvaged and returned and recycled, goes back to the bone marrow, and globin, like I said, is the protein that will be broken down back into amino acids, and we could use amino acids for tons and tons of other proteins to be made. Okay. So, in a very quick summary, what happens to the hemoglobin and to the red blood cell? The hemoglobin itself gets broken down into heme and globin. Globin gets broken down, which is a protein, gets broken down amino acids, and amino acids are used for many different things. All right, they're like the letters of your alphabet, and letters can be used for many different words. The heme itself is broken down into two things: iron and bilirubin. The bilirubin will go into bile, which is will get into the digestive system, and go out into your small intestines. Remember, bilirubin is a yellow dye, and that yellow dye can be broken down into two things: something that's water soluble and goes out your urine. That's why your urine is yellow. And part of it is water insoluble and goes out your stool. And if you want to make the color brown, you need yellow to be put in there. So the yellow in the stool comes from the bilirubin that's insoluble, that's water insoluble. So that's what gives the color of your stool and your urine. The iron itself is going to go back into the bone marrow, and it's going to make more red blood cells. When they last for 120 days, the liver is going to break it up with its macrophages, and the whole cycle repeats and repeats and repeats. So we have this recycling going on. Okay. You can see here step by step with the words, but let me show you this 2-minute video.
When old red blood cells rupture, the released hemoglobin is ingested by macrophages. The globin chains of hemoglobin are broken down to individual amino acids that are metabolized or used to build new proteins. Iron is released from the heme of hemoglobin. The remaining structure is converted to biliverdin, which is then converted into bilirubin. Iron is transported by transferrin in the blood to various tissues for storage, or to red bone marrow for making new hemoglobin. Free bilirubin is transported by albumin in the blood to the liver. Liver cells make conjugated bilirubin, which is excreted as part of the bile into the small intestine. Intestinal bacteria convert bilirubin into bilirubin derivatives, which contribute to the color of feces. Some of the bilirubin derivatives are absorbed into the blood and excreted from the kidneys in the urine.
All right, and everything is on here that was verbalized to you guys. This is what jaundice is. You can see here a normal colored hand, and here's a jaundice hand. Like I said, you can look at people and have an idea what's going on. Okay? Even the sclera of the eyes become yellow too. Okay? Now, anemias. Anemias only happen in 3 different ways. And there's different types of them. We'll go over a few of them. But there's only 3 ways that anemias can occur. It's either that the red blood cells are not being synthesized in a very fast fashion, so you have a decrease of production of red blood cells, or you're losing a lot of red blood cells. You cut your arm, blood is coming out. You're on your menstrual cycle, and they're heavy, and clots are coming out. You're losing a lot of blood. You're losing more blood than what your body can make, causing anemia. Or just that the red blood cells are being made, but they're defective. As I explained to you what spectrum was, or maybe sickle cells. In that way, they're being made, but they're deformed in some way. And basically, those are the 3 different ways that you can get anemia. And then there's subtypes of those. All right? It's either you're not making red blood cells, so it could be because you're not, the kidney disease is going to cause a decrease of erythropoietin. Or you can have any kind of marrow problems. If there's stuff not going there, vitamin B12 is not going there, or folate's not going there, or iron's not going there, you're not going to make red blood cells. All right? Or you're just going to be making defective red blood cells that won't function. Or the third reason is just we're losing a lot of red blood cells. All right? Either they're getting destroyed very quickly, or they're just, you got to cut, or bleeding is happening so much. Those are the only ways that you can get anemia. So anemia is due to a decrease in hemoglobin content. A good example is iron deficiency. You just don't have iron in your body for whichever reason. And that's going to cause some sort of anemia, in this case, iron deficiency. Easy way to fix it, you put iron back in your body, okay? In this case, the red blood cells appear pale and small, all right? So this is what normally it looks like, but here you can see that the translucent area becomes bigger. They become paler, and that's how you would tell the difference between the two. I won't ask you about those, but if you're going into that field, you might want to see that. There's also something called pernicious anemia. Pernicious anemia is basically you are not, you're low on either vitamin B12 or folate. Folate, folic acid, same thing. So it's due to that. There is, for instance, vitamin B12. There's also a certain tapeworm that goes into the body and takes away that vitamin B12 and uses it for itself. So it could be a tapeworm also. Either way, the vitamin B12 is not getting into your bloodstream, which isn't going to get into your bones to make the red blood cells. You could be just low on vitamin B12 in your diet, or folate for that matter. When you take in vitamin B12 by your mouth, it can't just get into the bloodstream. It has to ride on some sort of transport mechanism. There's something that comes from the stomach called intrinsic factor. Intrinsic factor comes out of the stomach, and intrinsic factor attracts the vitamin B12. Now, this intrinsic factor and vitamin B12 can get into the bloodstream. Vitamin B12 cannot get into the bloodstream without riding on the intrinsic factor metro. It must go on there. An intrinsic factor comes from the stomach. Now, if for some reason you're not taking vitamin B12, or you're a strict vegan, because vitamin B12 is found in meats, it's found in milk, it's found in that. But if you are a strict vegan, when you don't take any meat products or products that the meat gives you, sure, you will be low on vitamin B12, and you could get pernicious anemia. Okay? That usually doesn't happen until about a year, because your body holds on to vitamin B12 for about a year. But if you're a vegan longer than that, then yes, you will be needing that. Can you take vitamin B12 by mouth? You can, because your body's producing intrinsic factors. So you can take vitamin B12 by pills. But for some reason, if your body's not producing intrinsic factor, you can't be taking it by mouth, because it's not going to, the vitamin B12 won't be able to get into your bloodstream. So instead, we give you a shot of vitamin B12. Now that can go from the muscle, can go right into the bloodstream. It bypasses the intrinsic factor. You don't need that. I'm talking about dietary vitamin B12. It must ride on the intrinsic factor. So, and in this case, the pernicious anemia, whether you have a decrease of folic acid, and you don't need the intrinsic factor for folic acid or folate. You only need the intrinsic factor for vitamin B12. But if you're missing vitamin B12 and or you're missing folate or folic acid, you get pernicious anemia, okay? Meaning that you're not going to be making red blood cells. And their red blood cells appear larger than usual, okay? So this is what your normal red blood cells look like, and here's where pernicious anemia looks like. You don't have that pallor area in the center there, okay? Questions about that? Now you can actually answer the question, if you have part of your stomach removed or all your stomach removed, why would you be anemic? Why? Yeah, you can't produce intrinsic factor. See, the questions that I could ask on exam is just that, how to apply this stuff. You need to come into the exam knowing where this stuff is coming from. But for my exams, you need to know how to apply it. If you have kidney disease, why would you be anemic? And why? Why would you be anemic if you have kidney disease? What can't your kidney produce? EPO, erythropoietin. Okay? You see, you're coming into the exam knowing that erythropoietin comes from the kidney. You're coming into the exam knowing that erythropoietin increases red blood cells. Sure, you need those two facts. But my questions are, if you have kidney disease, why would you be anemic? It's the same thing, but you've got to know how to apply it. This is what I'm talking about in terms of wiring your brain for your future medical fields you're getting into, because they expect you to be doing that when you get in there. If you have your stomach, if you know that intrinsic factor comes from your stomach, and an intrinsic factor binds to vitamin B12 to get into the bloodstream to make a red blood cell, great. You know those two facts, and that's what that is facts. Now you've got to apply the facts. You have your stomach removed, why would you be anemic? It has nothing to do with the absorption of iron, which a lot of students would think. It's because you can't absorb the vitamin B12 because you don't have an intrinsic factor. All right? That could be a very good question on an exam, a final exam question. Compare and contrast how you are, what's the difference of getting anemia because you have your stomach removed versus your kidney fails. Sounds like a big thing, but you've got all the facts. You could do this. Okay? So anemia is due to abnormal hemoglobin. There's something called thalassemia. So really briefly about this, remember how a hemoglobin has 4 chains to it? If one of those chains is not being made properly, then it's going to be replaced with something that's not as efficient. We call that thalassemia. Okay? And we have thalassemia minor and thalassemia major. It's because of the chains are defective. Sickle cell anemia, we talked about that. okay, the cells become more of a sickle shape or a crescent shape or a crescent moon shape, okay? And that's kind of like what they look like this or over here, okay? Now, just the opposite. You have too many red blood cells. Then we call that polycythemia. Sure, we have a lot more oxygen in our body, but we have more red blood cells for whatever reason. If you have 4 people in each car, and you put more cars on the highway, how long is it going to, what's traffic going to be like? Very slow, right? So the same way here, you put molecules of oxygen on red blood cells, but we're increasing the red blood cells. Now there's more red blood cells in the bloodstream. Now to get from point A to point B is going to be much slower. Your blood will get more viscous, more thick. And that indirectly will increase blood pressure also, astronomically. We'll talk about those later on. All right? And we'll also talk about blood doping later on too. That's